Chapter 30, abdominal and genitourinary injuries. We'll start out as per usual with a little bit of anatomy and physiology. Most of this is a review, and it's a pretty much a current review because we only, with the layout of this class, did the abdominal and genitourinary emergencies a week, maybe 5 or 6 days ago. So we will cruise through the review portion of this. We'll get into some of the trauma and some of the patient care, and we will be on about our business of the day. So we know this, the abdomen, major body cavity, it goes from the diaphragm. The diaphragm is what separates the thoracic cavity and the abdominal cavity respectively. The most anterior portion of our abdominal cavity is going to be the diaphragm, and it extends all the way down into the pelvis. There are many organs, lots of blood supply, lots of room for problems in our abdominal cavity. Significant trauma to the abdomen, doesn't matter if it's blunt, doesn't matter if it's penetrating, doesn't really matter a whole bunch what it is. Can cause significant bleeding, can cause organ rupture, can cause fracture of our solid organs, and knowing a little bit of the anatomy that makes up our abdominal cavity is going to be important. So, something else we know, we've done enough patient assessments so to this point to know that the abdomen's broken down into 4 quadrants. We use the umbilicus as our dividing point. We have the midline, which goes superior to inferior through the body, connecting the nose, the mouth, the chin, and the belly button, and all points in between to make our left and right. Then we have a line that goes transverse through the belly button to create up and down, which gives us our 4 quadrants. When we palpate the abdomen, how are we going to do that? What's going to be our end game when we're palpating a patient's abdomen?
Placing 2 hands on each quadrant of the abdomen, pushing gently to feel for any types of distension, guarding, swollenness.
Good, that's perfect. The other thing we're looking for is rigidity. No matter how good a shape someone's in, when we palpate their abdomen, there's some softness there. It should feel like just normal, easy to palpate, easy to push on. We don't feel any real like areas of hardness. Because if we do, we can make a pretty simple look at something is wrong there, right? Especially now if we find that over an area that has sustained some sort of trauma. We don't have the ability to look and see, but just by putting our hands on the patient and doing that portion of our assessment, we know that the abdomen's not supposed to be rigid. If it is rigid, it's a clinical finding, and it's a clinical finding that's indicative of something is leaking into those tissues to make this portion of the abdomen hard. What that something is going to depend on our location for the most part. We see bruising, we see tenderness, we see rigidity, we see distension, and it is going to start pointing us towards, are the underlying organs of this particular abdominal quadrant injured, or do we just think that they're injured? Because we can never really say for a definitive fact that they're not, right? Do we have any ability to say that?
No.
Right. We've gone through enough of the kinetics of trauma and the way that force is applied to the body to understand that the tissues themselves are not going to soak up all of that energy. So there will be some suspected underlying injury to whatever organ lies underneath that abdominal quadrant. Our hollow organs, there's a bunch of them. We have the stomach, the intestines, ureters, the bladder. For the most part, they are involved in digestion and the excretion of waste products. When ruptured or cut, those contents are going to spill into the abdominal cavity, causing that peritonitis, that inflammation of the peritoneum, and causing an inflammatory reaction throughout the body. What kind of pain do you think that sounds like? When those contents spill and leak out into the abdomen and they're floating all around in there.
Pressure pain?
So I'm not even really looking for necessarily the quality, but do you think they're going to be able to point to that spot and be like, wow, this hurts right here?
No, it's going to seem more spreaded out since it's spilling into all directions.
Yeah, and that inflammation is widespread and the pain is going to be a little bit more spread out. When a hollow organ ruptures and leaks its contents like that, it can in fact be serious and life-threatening. And if you think about, downstream now, if all of that is filled with waste products, that's exposing all of these internal organs to infectious material that are normally kept inside of that organ. And then if you think about how much blood supply there actually is around, the 30 some odd feet of intestine we all have, because it's wrapped in a mesh of capillaries and veins and arteries so that we can feed our body with the food that we take in. Not only can it be life-threatening downstream, but it is possible that it causes a significant enough leak inside of our patient that we could start to see some hypovolemic shock. We start to see signs and symptoms of shock from hypovolemic with a hemorrhagic cause, but never get to see any blood. Which is why when we're evaluating this patient, we're looking for that tenderness, rigidity, distension, guarding, any bruising. When we have a significant amount of blood lost into the peritoneal cavity, we can actually see almost half of the patient's circulating blood volume has leaked into the abdomen, and maybe we don't see a single sign or symptom other than some of the outward stuff we're looking for. If we have that much blood just free floating around in the abdomen, let's say we've done our inspection, palpation, auscultation of the belly, and maybe we found nothing when we did that. What are some other things that my patient might be showing me to tip their hand that they're not doing so hot?
Curled up in a fetal position, agonizing
Okay,
pain.
some pain, I'll take that. Anybody else? What's this patient going to look like?
Pale, clammy.
Pale and clammy. So what am I seeing? Signs and symptoms of what?
Shock.
Yeah. And it's going to be one of those times where you look at the patient and go, wow, they look kind of like crap. They look shocky. They have a rapid pulse. They have a rapid respiratory rate. Maybe their blood pressure is just a tick below normal. And they're sweating, but they're cold. And you look at them and you go, well, what is going on here? And you get through that initial rapid trauma assessment, you get them to the ambulance, you get your first set of baseline vitals, you get a sample history if you can. And then when you come back and you reassess where that injury was, then you start to see some of those outward signs of the underlying injury. Now they're shocky, maybe their heart rate is faster, maybe their respiratory rate is faster, their skin still looks kind of crummy. But now we start to see some of that rigidity and maybe some more tenderness and maybe some more diffuse, widespread pain along the abdomen. And it starts to now make sense. Those dominoes start to fall. And you say, all right, now I'm on the right track because I thought their abdomen was injured. And clearly, since they're progressing in the negative and I'm seeing now signs and symptoms of injury to their abdomen, whether it's one of these hollow organs on the left or our solid organs on the right, it's beginning to present itself to me. So you were right all along when you were thinking shock and you were treating for shock by keeping them warm, laying them as flat as you can, and oxygenating them. And now you're starting to see, all right, if we draw our imaginary abdominal quadrant here, so we have our 4 quadrants. I draw them on the other picture as well. What kind of pain do we expect from those lower quadrants? Let's look over here. What types of organs are in our lower quadrants?
Bladder, appendix, female fallopian tubes, uterus, rectum.
All right, so you're rattling off a bunch and you're absolutely correct. Hollow or solid?
Hollow.
All right, so what kind of pain might my patient describe to me?
More of like a radiating pain?
So yeah, all right, I'll take radiating, why not? More like widespread, spread out, diffuse, difficult to localize. Now what if we're dealing up here? We have a different set of organs, different type of stuff in our upper quadrants for the most part, right? There's some hollow organs in the upper quadrants, but what's there mostly?
Solid organs.
All right, our solid organs. Our solid organs are a lot more susceptible to direct trauma, blunt trauma, things that are actually going to cause that solid organ to fracture and break apart. The liver, the spleen, the pancreas, the kidneys, they have a huge blood supply and a big role in the storage and production of blood cells. So when we see direct trauma injury to those upper quadrants, we can already start thinking, even before my patient shows me any signs of symptoms of shock, maybe they are absolutely complaint free, but I know injury to the upper quadrant means a lot of bleeding. A lot of bleeding is something, especially if it's internal, there's not much I can do with. So I need to be on my game about making sure that we get out in front of signs and symptoms of shock, because this bleed is going to go on unchecked. All of these organs, if they have sustained injury, they are absolutely going to just bleed. So there's no fixing it, there's no stopping it, there's no slowing it down. So being aggressive for the patient who's likely to deteriorate from that blunt trauma, from that penetrating trauma to our upper quadrants. The liver is a really big organ. It kind of hangs out in space a little bit below the bottom of the rib cage. It is very susceptible to sustaining injury and causing a life-threatening internal hemorrhage. When we are classifying injuries to the abdomen, just like any of the other traumatic injuries we talk about, we're going to talk open versus closed. They can involve hollow organs, solid organs, blood supply, or any and all of the above. Most of the time when we're looking at closed abdominal injuries, we're talking blunt force trauma to the abdomen because it doesn't actually break the skin. When we have people who don't put their seatbelts on correctly, when we have people that are hit by motor vehicles, even in motor vehicle collision where we have a patient who is properly restrained, that shoulder belt comes across the patient's abdomen. And depending on which side of the vehicle they're sitting on is going to depend where we will see that lap belt causing the most damage. We see a lot of blunt trauma to the abdomen when you talk things like assault. We can see penetrating trauma when we talk about different kinds of assault. It all depends on how the patient was assaulted. Our signs and symptoms can be tricky. We can see very sort of diffuse pain. We can see pain that is referred to another location. Blood in that peritoneal space. This is the take home. blood in that peritoneal space is going to be acute pain in almost the entire abdomen. Things are leaking into that abdominal cavity that are not supposed to be just out there floating around in space. As more cavity is taken up by blood, we'll see more rigidity, more distension, more tenderness, more guarding. We'll see more contraction of the abdominal muscles, but it's not always based on how much pain the patient is in. We do see difficulty in our patient's ability to determine where the pain is because it has become so diffuse when those peritoneal cells and tissues are being aggravated by all the abdominal contents or free-floating blood spilling into the cavity. We may never actually see the bruising that we're looking for. How come?
Because it could take a long time to form.
Yeah, bruises take some time to develop. That blood's got to get into the tissues and break down and start to discolor. So again, we'll get into the habit of treating based on suspicion, or at least, having our suspicions. If we see abrasions across the abdomen, it probably took a significant amount of pressure, unless, your patient had a slip and slide accident or something like that. It probably took a significant amount of pressure to abrade that tissue and give it that look. So it's always one of those things, again, that we keep in the back of our mind that, hey, this could be worse than initially advertised, and it's something you need to go back and check on. We'll see a picture here in just a slide actually, about how our seatbelts can cause us some injury. When we talk about pregnant females, we're going to do a bit of conversation about that tomorrow, and I think on Wednesday as well. A pregnant female's bladder actually gets distended and pushed towards her anterior, so it gets pushed down and pushed forward. So even a properly worn seatbelt, like we see right here in the picture, has the ability to damage the bladder of a pregnant female. If we have a seatbelt that's worn incorrectly, like we see in the upper two pictures, you can see that when we have that sudden deceleration, when we have that blunt force trauma applied, you'll see compression of, in this picture, it would be the lower portion of the rib cage. It would be the right upper quadrant, so the liver. We also see some of the intestines in the lower quadrant being sort of just squished and having that widespread force applied to them. And this is likely to cause absolutely no external hemorrhage at all. Our ruptured bladder, when we're talking a pregnant female, what's something that might tip you off that we've had a problem there? Say you show up to a motor vehicle collision with a pregnant woman who's just ruptured their bladder.
Blood in
Say that once more.
some blood in the urine.
Some blood in the urine and probably incontinence, right?
Mhm.
Because if that urinary bladder is connected to the outside, it's got a direct route to the atmosphere. So if we show up to a trauma and our pregnant female has soiled themselves and we see some blood now leaking from our patient, we know that it is very, very likely that that bladder has sustained some form of injury. Do we know whether it's ruptured? Do we know whether it's just got a tear in it? Do we know really anything of the inner workings? Not so much, but it's a pretty easy dot to connect. And that's really a lot of the times what we're doing with these closed injuries, especially to the abdomen. There's just so much stuff that could be wrong. And abdominal pain, whether it's from a trauma or from a medical cause, is very, very difficult to figure out in the field because the pain winds up very diffuse, sort of widespread. Now, as far as our open abdominal injuries, well, this makes life a little bit easier, right? We have something has penetrated our abdominal cavity. Open wounds also can be deceiving. We expect, if there's a lot of blood, we expect to see a lot of blood, right? But is that always the way that it happens?
No, sometimes you might not see any blood at all.
Right. That hole could be leaking just internally, especially if our patient has fallen. And now where's all that blood going?
Gravity, lowest part of the body, inside somewhere.
Gravity. You're absolutely spot on. Damage is going to depend on the velocity of the object, true. But just because we don't see a big leak doesn't mean that there isn't one. If we see a small caliber handgun wound to the right upper quadrant and there's no blood spilling onto the ground, you're spot on, Alex, by saying follow gravity. Gravity is going to pull that blood to the lowest possible place, and it's going to begin to fill up the lower quadrants of your patient's abdomen. They're going to have that widespread diffuse pain on top of the pain that goes along with, the gunshot wound in the belly. Bullets don't always travel in straight lines. They have the ability to hit things and bounce off things and go in there and play Pac-Man and cause all sorts of havoc. So just keep in mind that just because there's not a big leak on the ground doesn't mean that there's not a big leak on the inside. We covered a lot of this a little while ago. Our low velocity low velocity injuries are going to be anything that is person propelled. So knives, sticks, pipes, swords, whatever, screwdrivers, that's going to be a low velocity injury. Our low velocity injuries are going to have a much more specific injury pattern. Then when we start getting into medium and high velocity, so our medium is going to be handguns and shotguns. Medium is going to have that temporary wound cavity that we talked about. I'll bring up a ballistics gel test and show you sort of a live version of what we're talking about when we talk about that cavitation and that temporary wound cavity versus the permanent wound cavity and how it changes depending on the muzzle velocity of what the patient's been shot with. Cavitation is what causes that. When the bullet goes through and causes that pressure wave throughout the tissue, that cavitation is going to be caused, whether it's medium, whether it's high velocity. It's just the faster a projectile is moving, the more pressure it is sending through the tissues, the bigger our temporary wound cavity is going to be, and the more tissue damage it is going to cause, which means more bleeding, more devastation. Our low velocity injuries, we may not see much in the way of really internal injury. We probably won't see a lot of, apparent, easy to figure out internal problems. We'll see some blood because, well, they had to cut tissue to get in any deeper, but whether or not a liver has actually been lacerated, whether or not a stomach has actually been punctured, whether or not our edged weapon has gotten deep enough to actually penetrate intestines and cause all of that infectious material to leak out is going to be something that is up to the trauma physicians to figure out. Injury at or below the xiphoid process. So that little piece of bone that hangs off the bottom of your sternum is called the xiphoid process. Any injury there or just below can actually cause problems with both the thoracic and the peritoneal cavities. When we talked chest injuries and you guys read up on that chapter, you saw about diaphragmatic rupture. This is entirely possible, a thing that could happen if we have a penetrating trauma at or below the xiphoid process, because the diaphragm lives right there. Remember, it is the topmost portion of your abdominal cavity, but it is also the lowermost portion, so the most inferior portion of your thoracic cavity. Abdominal eviscerations. Does anybody remember what this was?
When your organs are coming out.
Yeah, insides are now officially on the outside. How are we going to treat this?
Plastic bag, keep it warm and moist.
All right. Trauma pad over it, keep it warm and moist. I like it. Can be painful and visually shocking to look at. Yeah, I think we can all get on board with that. Don't push down on the abdomen. Why?
You'll push more of it out and be
Yep.
very painful.
Any pressure is going to make more of it come out like we're working a sausage machine. Only perform a visual assessment. We want to cut clothing close to the wound, but we want to be really careful that we don't wind up nicking any of that protrusion. If it's not cut, if it doesn't have some sort of laceration to it, that's great because it means all of that intestinal content is still inside the intestine. Sometimes you can actually smell a whiff of bowel and you'll know that intestine has actually been compromised. If something is stuck to the wound or in the wound channel, leave it stuck there. It's not really going to be that big of a deal. We have much bigger fish to fry at this point. What do we expect for signs and symptoms? Well, pretty straightforward. We're going to see an increase in heart rate. So we'll have some tachycardia. Body's trying to compensate for blood loss. And what chemical has it released in order to try and compensate for that blood loss?
Epinephrine.
Epinephrine. So we've got epi on board. Our patient's going to speed up. We're going to see peripheral vasculature starting to clamp down and close off. So we'll see that pale, cool diaphoretic skin. We'll see an increase in heart rate, increase in respiratory rate, maybe some alteration to their mental status. Maybe there's an even bigger mess underneath the patient's abdomen. And that little bit of eviscerated bowel isn't necessarily the biggest problem that this patient's having, and we'll see some distension. Just treat it as an evisceration and be on your merry way. Why do we think hollow organ injuries will a lot of times have delayed signs and symptoms? We have all sorts of.
They're not under direct pressure of blood or any type of substance, and don't know.
No, you were close enough. What are most of those hollow organs house? It's not really blood, right? They have blood around the outside of them, but what do they have inside of them?
Bile.
They have bile. They have the byproducts and waste products of digestion. So sure, we may see some abdominal pain. We may see, some signs and symptoms of injury, but how injured the patient is may not actually show up because it takes a little while for the toxicity and the acidity to actually now spread throughout the peritoneal cavity and cause that widespread diffuse issue that we think of. Those contents are toxic. They are bad, nasty to have just floating around, aggravating all the tissues on the inside. They're supposed to be in the intestines, but that doesn't mean it always just the minute the injury occurs, we see those problems. That's our hollow organs. They might take a little time to develop. My patient, may not have much in the way of complaint when I show up. And then as we progress, we'll see the patient beginning to get a little worse.
This be your septic shock?
Well, it's funny you should mention that because we can start to see our patient developing septic shock. Most of the time, that'll be a little bit further downstream. The organ will actually pop and rupture and spill its contents. Obviously, penetrating trauma is going to cause that direct injury to that spot. And we'll start to have some air in the peritoneal cavity causing pain, sure. But most of the time, what's going to be this patient's biggest enemy is all of that bacteria-related laden stuff just leaking out and continuing to leach into the tissues and causing those signs and symptoms of septic shock. So we'll start to see them now, maybe a day or two later, hot to the touch, altered, hypotensive, tachycardic. They'll be red. Why are they going to be red instead of pale, cool, and clammy? Somebody reach back into the Wayback Machine and tell me what's different about septic shock.
Something, the blood rushes to the skin.
Yeah, because of that wide scale vasodilation, they start to actually look flushed and hot to the touch and altered and hypotensive and tachycardic. And we can see that the injury that they had a day or two ago that maybe they ignored because they didn't have that really sudden onset of significant pain caused them to now, a day or two later, develop some septic shock symptoms. And really, this is the patient right here, the like stereotypical abdominal trauma patient that is not going to do well because those, whatever has leaked is just so toxic to everything else. And now if we see septic shock, what does that tell us?
That you're at the end stage.
You're at the end stage, and is that now still a localized infection?
No, it's made its course throughout the whole body of the abdomen.
Yeah, we're talking huge systemic problem here that is going to be way more difficult for the definitive care to actually take hold. When we talk our solid organs, they can bleed significantly rapidly, or they can just slowly ooze into the peritoneal cavity. Your patient is really going to present one of two ways. They're either going to look very hypoperfused right away because they've lost a ton of blood into that abdominal cavity, or it's going to be a slow roll. They're going to be a little bit slow in developing. And does it make any difference to us?
Nope.
How come?
Because there's not much we can do either way, so just transport.
All right. And concentrate on the things we can have the greatest effect on. So we know that these injuries are likely to produce shock of some sort. We know that these injuries are likely to produce blood loss or spillage of contents of some sort. So our best bet is treatment of that. Monitoring the things that are keeping this patient alive, like their vital signs, their airway, their breathing, their circulation. And you couldn't have said it better, transport. We know that these injuries are likely to have occurred. And it doesn't really matter to us whether they actually really have occurred or not. What we want to do is make sure that the patient does not get any worse from the moment we walk in the door until the moment we drop them off. That's where our concentration lies with a patient who legit we have no ability to fix. Anything that's broken or messed up down there is going to be some form of surgical intervention. And our job is to make sure this patient is as bright-eyed and bushy-tailed as they were when we leave them. Our spleen and our pancreas, very vascular, very prone to heavy bleeding. If the diaphragm is penetrated or ruptured, our patient is likely to have some complaints of difficulty breathing. Remember, the diaphragm, as much as it is the dividing line between thoracic and abdominal cavities, it is also one of the most integral parts of ventilation, the patient's ability to get gas from the inside to the outside. Our abdominal contents may wind up in the thoracic cavity. And so now we have more things taking up the space that our lungs need. We have a diaphragm that's compromised and unable to create that pressure difference. So it's unable to contract and pull towards the anterior and inferior portions of my body. So now it's all on my intercostal muscles. And think about if the diaphragm ruptures, and its job is to be an airtight seal for that vacuum. Think about how much more cavity there is now. It's going to be more difficult for our patient to actually create that pressure difference because there's no more pressure in the thoracic cavity. Now the thoracic cavity and the abdominal cavity are all connected, and your patient's going to struggle to breathe. This is a patient you may wind up ventilating if they've had rupture to the diaphragm or penetration to the diaphragm. And we see, maybe blunt trauma right at the level of the xiphoid process, maybe just below the nipple line. And your patient is complaining of sudden onset, some real significant difficulty breathing. When you lay them down, their difficulty breathing gets worse. Why do you think the difficulty breathing would get worse if you laid that patient down?
The diaphragm is not able to rise because of a puncture wound, and it won't be able to fill up to do its job.
That, and if we lay them flat, more of that gets to invade the space. So we have now more of those abdominal contents just sort of sloshing their way into the patient's thoracic cavity, and their respiratory distress becomes even a little bit more distressing.
So how would you transport, like a Fowler?
Yeah, probably semi-Fowlers. They probably don't want to be bolt upright either, because I'm sure that would be painful. Even when we start talking about how we're going to treat people in the field, and we switch gears after you guys have passed all your exams, and I tell you that backboards are witchcraft and we don't do it. Full spinal immobilization for us means a seat collar and secured at a 45-degree angle on the stretcher. And that's probably someone who would do very, very well.
Gotcha. And for eviscerations, it's going to be supine?
It is, but they don't have to be flat, right? We can allow them to bend their knees up. We can sort of pad it a little bit so that we don't have them stretched out completely with a lot of pressure on their abdominal cavity. Flat for that person, yes, but straight out and stiff as a board, probably not.
Thank you.
Yep. So figuring out what is going on with our patient's injured abdomen is not easy as far as from an assessment point of view. We may see injury staring right back at us. You won't miss an abdominal evisceration, I promise. It's, whoa, wow, that's supposed to be on the inside. But the tissue damage and the things that are a little bit more slowly developing and slower to cause pain may not jump right out at you at first. The patient, sure, maybe they're a little uncomfortable. Maybe they just chalk it up to, wow, that seatbelt really cranked me good. Maybe they have multiple other problems going on and it's distracting them from that abdominal injury, which is why if you suspect, you need to investigate. It doesn't really make a whole bunch of difference in the grand scheme of things if the airbag broke both of my patient's thumbs and that hurts really bad, and they're complaining about their thumbs alone while they have a laceration to their liver because the seatbelt actually also broke one of their bottom ribs and cut the liver wide open. And now we're seeing some abrasion, we're seeing some distension, we're seeing some swelling, and a little bit of rigidity maybe as more and more blood begins to leak into those tissues. Don't miss the forest through the trees. Part of our primary assessment is going to be to sort of try and figure out, is this a right now injury or did this happen previously, because it can take a little bit of time to develop. Get your general impression. You know, don't get distracted by other things that you see. Follow your natural progressions. Look at your patient, talk to your patient. Are they responding appropriately? Make sure that if we see any gross external hemorrhage, that we are going to stop what we're doing and fix that. And then we move on to the rest of our primary assessment. The rest of our primary assessment being what? We've gotten our general impression. We've addressed any life-threatening external hemorrhage. Let's say we've gotten our patient's level of consciousness. They're alert. They're talking to us. They've answered all 4 of our questions appropriately. What's my next step?
Vital signs, ABCs.
ABCs. Yeah, don't get those 2 confused. Our next step in our primary assessment is going to be ensuring that my patient has an open, clear, and secure airway. Ensuring that my patient is breathing and has adequate rate, rhythm, and quality. Ensuring that my patient has a pulse and getting the rate, rhythm, and quality of that. Doing my sticky test to make sure that I didn't miss a life-threatening external bleed that is maybe being hidden by clothing or the ground. Getting my skin color, temperature, and condition. Putting this patient on oxygen. Using an airway adjunct if I have to, if they're not speaking to me. And making my decision. I'm going to treat this patient aggressively for shock. I'm going to bring them to the closest appropriate facility with an ALS intercept en route. And then we are going to get on about the business of identifying what this problem is. If we think we have an abdominal injury, open or closed makes absolutely not much difference to us. It's going to be indication for rapid transport, because it's going to be indication that my patient has something injured underlying that I can't actually identify the severity of. Let's see what else we got going on here, because let's say we're in our secondary assessment. We'll have a hypothetical question here. We're in our secondary assessment, and this patient tells you that they fell while cleaning out the gutters from the garage. They landed on, let's say, a piece of like wrought iron railing. No points, nothing penetrating. It's a closed abdominal injury. It happened 3 or 4 hours ago. They called 911 because they felt a little lightheaded after they went to the bathroom to move their bowels. And now they're kind of pale, sweaty, and they tell you that their last bowel movement that they just had was black and tarry and also had some frank blood in it. What do you think's going on?
internal.
Internal bleeding. The blunt trauma could have punctured or ruptured his stomach, leaking content into it, and
And that's what's that? A melena?
Yeah, I think that melon is the blood in the stool. Yep. So do you think this patient's sick or not sick?
sick, definitely.
And let's think of some of the things that we saw and some of the things that our patient told us. We saw the changes in skin color, temperature, condition. We were able to palpate and quantify what their heart rate was, whether they were warm or cool or cold. They told us about signs and symptoms of internal hemorrhage. And then now let's click back for a minute and think of how long that had actually been going on for. before those signs and symptoms of that internal hemorrhage actually reared their ugly head, went and sat down on the toilet, went to get up, got lightheaded, and this is hours downstream. And then finally, when he went to evacuate his bowels, noticed there was some bleeding, and this has been going on for an hour, 2, 4, and never anywhere in there did I mention anything about any increase in pain. And this could be a legitimate, actual patient. That could be a real thing. And the word pain never came up. It was, I sat down on the toilet. I had a fall earlier. I sat down on the toilet. When I went to stand up, the room just started helicoptering on me. And then I looked, and wow, it was weird when I went to the bathroom. It looked like, like somebody had dropped pothole repair in the toilet. You think, oh boy, this has been an unchecked bleed going on since the patient took a Dixie off the roof of the garage. And you start adding those things up. And I didn't see a drop of blood in that situation. I have no idea whether there's a quantifiable amount of blood loss, but I can see signs and symptoms of shock. My patient can tell me that they just lost however much amount of blood into the toilet, and it starts building my case. And I'm not judge, jury, and executioner here. I don't even have to be right. All I need to do is treat appropriately. All right, I have almost 9:30, so why don't we take our first break? We'll get into the genitourinary system, and we will see what else we're going to get into today. So I'll put 15 minutes up. When we come back, we will finish off chapter 30, and we'll get into chapter 23. All right?
That's good.
All right, we are back and getting after it. Now we are going to talk the genitourinary system. Genitourinary system is responsible for the reproductive functions and getting rid of waste products. They are located in the inferior-most portion of our abdominal cavity, so down towards the pelvic portion of our abdominal cavity. We have the kidneys, the ureters, the bladder, and the urethra. The genitals of a male patient are going to be outside the pelvic cavity when we talk anatomy of the reproductive system. And in our female patients, the organs of reproduction are all internal organs. Here we have front and side view of the male anatomy and our front and side view of our female anatomy. When we talk about injury to the kidneys specifically, part of the genitourinary system, very, very infrequently do injuries to the kidneys happen all by themselves. So an isolated kidney injury is very uncommon. Why do you think that is?
Because they're protecting.
You got
It's
it.
more.
Go ahead, Alex.
No, none. You got it.
Yeah, they're very well protected. They have lots of tissue and lots of structure protecting them from the front. And they have a very rigid cage-like structure of our rib cage and our spinal cord and spinal column protecting them from the back. Penetrating injury or a very, very forceful blow is generally required to cause injury to the kidney. Excuse me. We can suspect damage to our kidneys if our patient has an abrasion, a laceration, or contusion on the flank. So the flank is sort of where like the mid-axillary line runs through. Our flank of our patient is going to be sort of their side, and it kind of bridges the gap a little bit between anterior and posterior. If we look at some of the words that are in that first bullet point though, deformity, contusion, abrasion, punctures, penetrations, burns, tenderness, laceration, and swelling. We lump all that stuff together because it's what we're looking for as significant findings, and it's part of our DCAP BTLS. Obviously, anything that penetrates the abdomen and the flank or upper portions has the ability to penetrate the kidney as well. The lower portions of the rib cage or the lower part of our thoracic or upper lumbar vertebrae can also point us in the direction of a possible injury to the kidney. And since the kidney is a solid organ, we know that it has a very rich blood supply, very, very vascular. So if we start to see a hematoma or a really, really large sort of darkly colored bruise beginning to form on that flank region, we know that the underlying thing that is most likely injured is going to be the patient's kidney. When we see injury to the bladder, we think of rupture. Urine spills into the surrounding tissues. So if we have urine spilling into those surrounding tissues, we're likely to see very, very diffuse pain in the inferior-most portion of our patient's abdominal pelvic cavity. This can be caused by blunt injuries. It can be caused by penetrating injuries. Really just about anything, especially if the bladder is distended and filled with urine, it's more likely to be susceptible to things like rupture. And then if you start thinking about this right here, if a patient has a pelvic fracture or a hip fracture and we have sharp bone ends near that distended bladder, we can actually have holes poked in the patient's bladder that will cause leaking of the contents into those surrounding tissues. We're going to talk soft tissue injuries to the genitalia here for a minute. It's like any other soft tissue injury. It's just likely to be a bit more concerning to your male patient, I would imagine. It can be painful. There can be a significant amount of blood loss. We just need to make sure that we're not missing other more important things like airway, breathing, circulation. A significant soft tissue injury to your patient's genitals is not likely to be life-threatening, but it is probably something that your patient is going to be most concerned with. That's one of the things we talk about when we talk distracting injury. I know personally, if I had sustained some form of soft tissue injury in the genital region, it would be rather distracting for me. It's likely to be the same for our patient, and it's what they're going to focus on and is what they're going to be concerned most with. And we have to be sure that we're dotting our I's and crossing our T's. The female internal genitalia is mostly hollow organs. We have the uterus, the ovaries, fallopian tubes. They are very well tucked inside the pelvis. They are very well protected by thick muscular structures, and it is very uncommon that the internal female genitalia is damaged, unless, of course, your patient happens to be pregnant. If your patient is pregnant, the uterus enlarges and rises well up out of the patient's pelvis. It takes up more of the inferior portion of the abdominal cavity. We also have two patients at that point in time. Injuries can be serious. The uterus can actually, as it grows, it thins out a little bit, so it's a little less muscular, a little less thick. We can actually have traumatic rupture of our patient's uterus, and that can be a significant finding with, dire and devastating outcomes. The female genitourinary system also has some external pieces. We have the vulva, the clitoris, the major and minor labia, very, very nerve rich. They are very, very much blood rich, and they are likely to cause a significant amount of pain, a really significant amount of pain, and a significant amount of bleeding. But again, neither of those are likely to be in life-threatening nature. We're not going to insert anything into our patient's vagina. We're going to use sterile sanitary pads that we carry on the ambulance. If we have an avulsion of any of these external pieces, we're going to treat them like anything else. So it was just like our degloved finger. We find the tissue, moist, sterile dressing, keep it cool, not cold, moist, not wet, and transport it to the hospital. The most important part of what we talked about here is this bottom bullet point. And remember, every time I have to say something like this, it's because somebody did it. So there's nothing we're going to do to control that bleeding. And the one thing we need to do is just sort of remain and maintain our patient's dignity a little bit and transport them. These are also injuries that are not very common as far as, normal and righteous causes. So always keep in the back of your mind, you're going to be mandated reporters here in the not too distant future. Always have in the back of your mind that injury to the external genitalia of either a female or a male patient is very unlikely, right? It's not something that is very common. So always think possible sexual assault and victim of violence when you are evaluating a patient for something like this. If the story doesn't play out, then, start thinking that there's other causes at hand. For the most part, this is going to be embarrassing for our patient. This is probably one of those times where if your patient is female, they're going to much more prefer to be evaluated by a female provider. And if your patient is male, going to much more prefer to be evaluated by a male provider. Provide as much privacy as you can. Anybody that doesn't need to be there can take a hike. look and see if you see blood on the patient's undergarments or on their clothes in general. It'll help you start to gauge how much blood are they actually losing. If someone is soaking through their outer clothing, we have a pretty significant amount of hemorrhage at that point, and we need to make sure we are doing what we can to get this patient to the emergency room, because it's likely to look like a lot of blood. It's likely to be uncomfortable for all parties involved. And if it's not life-threatening, I don't really need to do this big, whole, huge assessment on this area, right? I'm going to look for the things that jump out at me and make sure my patient doesn't die. Pretty straightforward. One of the things that everybody likes to skip over in their rapid trauma assessment, and we'll cover it here and we'll talk about it again when you guys get in, is when they get down to the pelvis, right? So we're palpating, we're doing that rapid trauma assessment, our secondary assessment, and we're inspecting, palpating, and auscultating. We're looking for deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. They get all the way down to the hips and the pelvis, and then they completely breeze by the fact that they're supposed to inspect, palpate, auscultate, and check for deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling in the genitals and perineum area. Like, people don't even like to say it, let alone think about the fact that they have to assess for it. Don't skip it, because it is likely to have negative consequence. We can see a significant amount of blood loss here. All by itself, is it likely to be life-threatening? No. What I'll also tell you is it's uncommon that we will see trauma to just this area. So we're not talking about injuries that are occurring all by themselves. We're talking about injuries that are occurring in, a widespread area on this patient. And at that point, any blood loss is too much blood loss. These can be significant trauma patients. What are our interventions going to be for this patient? Pretty much status quo. Oxygenate, treat for shock, maintain an open airway, control any external hemorrhage, put them in a position of comfort, and communicate and document. We are going to make sure that we provide care and treatment for the things that we can. We can always oxygenate someone we think is in shock. We can always provide as much care and comfort for someone who has sustained this type of injury. We can always either monitor their airway if they're maintaining it themselves, or control their airway if they've lost the ability to do so. Your patient's mental status is starting to progress in a downward manner, and they're starting to really, not do so well. Get ready to put an airway in. Get ready to ventilate. There does come a time where we need to get out and get these problems sorted out, because my patient's body is losing the ability to do so. If we're talking kidney injuries, we could see signs and symptoms of shock if it's an injury from right now. If the patient has sustained the injury and some time has passed, a lot of the times the complaint on top of pain is going to be some frank blood in their urine. Blood in your urine is not something that most people see. So it is something that the patient will absolutely generally call 911 for if they're starting to see some blood passing through their urine. The same can be said for our urinary bladder injuries. This is not always something that 911 is activated immediately for. If it meshes with our trauma assessment and our patient's complaint and the mechanism of injury we're seeing on scene, we're thinking signs of trauma to the lower abdomen pelvis. If this is something that gets called in afterwards, we're likely to see frank blood at the urethral opening. It's not going to be mixed with urine anymore, because that urinary bladder is no longer intact and storing urine, we're going to see actual bleeding coming out of our patient. If we have injury to the male external genitals, we're going to make the patient as comfortable as we can. We're going to, I guess, use moist sterile dressings at this point, just to sort of clean off and care for any areas that have been sort of stripped or abraded of skin. If we're going to put a dressing, we're going to use a dry sterile bandage. We're going to control any hemorrhage we have to. If there is some form of foreign object inside our patient's urethra, people will do the damnedest things. Don't try to move it. Don't try to manipulate it and remove it. Leave it be, and they will take care of that with a urology consult, I'm sure. Same care goes for any avulsed part, male or female. Moist, not wet, cool, not cold, and off to the emergency room. And I'm sure you'll have a very strange conversation with the doctors and nurses when you walk through the door and they ask who's got the member in the bag. Managing blood loss is our big priority. It is likely to be very painful. It is likely to be very distracting. One of the next ones is if your patient gets caught in their zipper, we are not going to try to unzip. We're going to control any bleeding, any sterile dressing that we have to or that we can. And we transport to the hospital. Most of the time, the patient will have already unzipped themselves by the time we get there. Female genitalia, gonna be exactly the same as far as a management perspective goes. Treat lacerations and avulsions, control any external hemorrhage. If any parts have actually been removed, bring them to the emergency room with you. This will require in-hospital evaluation. There's a lot of specialty involved in urology and injury to the genitals, whether they're male or female. And this is not something that should go unevaluated. This is not a patient who just says, I'm not going to the emergency room, and we let it lie at that. I will absolutely argue with a patient about being transported to the emergency room rather than being left at their house about just about anything. This is definitely one of those times where I am not going to just go quietly into the night and let this patient deal with this on their own, however they see fit. Because as much as it might not be a huge, terrible, all-consuming problem right this very second, it's likely to be a huge, terrible, all-consuming problem for them in the very near future, and they absolutely need to be evaluated. Man, we couldn't have this lecture without talking about sexual assault. Sexual assault and rape are common and becoming more and more common. Victims can be any walk of life, men, women, children. Very, very little we're going to be able to do for this on a strictly by the book, talking about how we're supposed to treat and what we're supposed to do. Know that there could be underlying issues. This is generally, comes hand in hand with violence of some other sort. So be on the lookout for blunt, penetrating, you name it, any kind of traumatic injury that you can come up with. People that are going to inflict these types of crimes on others are generally very much going to inflict other types of pain and discomfort on them as well. If our victim is the victim of sexual assault or rape, we want to do less. Doing less is doing more. Document everything that you can. probably don't do a whole lot of inspection, palpation, and auscultation, because is it really going to help?
No, and if it's a rape victim, you don't want to touch anything because it's going to have to be taken in to be investigated on.
Right. I mean, you are officially at a crime scene. So we want to make sure we are handling things as little as possible. We want to try and get the patient not to clean themselves, brush their teeth, anything until after they've been evaluated. People are going to want to do that. They're not obviously going to be in the greatest of mind frame about what they just experienced and what just happened to them. If there's injuries that need to be treated, we treat them. If there's things that need to be handled and done, we handle them. But we want to sort of use the kind of kid glove mentality with this and do as little as we have to. I mean, it's clearly we don't let people die just because, but you know, less is more. Plenty of people are going to be poking and prodding at these poor folks, and we don't need to be another just person on that list. If you wind up collecting any evidence, it goes in a paper bag. Plastic bags are just a breeding ground for mold and mildew and ruining evidence. Paper bags are where it's at because they actually will soak up any of the evidence that could really be lost. Yeah, when we talk about abuse and elder abuse and child abuse and all that stuff, these are not my favorite topics, to be perfectly honest with you. I mentioned being a mandated reporter. A little bit later on today, I'm going to send out a couple of links, because sooner rather than later, on top of being mandated reporters, you guys going forward as firefighters and EMTs are going to need to complete some FEMA stuff. ICS 100, 200, and 700. Some of you may already have them from time in the military or whatnot, but I'll send out how you register for them and how you go about getting them. And when you come in today, we'll talk about that stuff. It's not a big deal. But that has been our abdominal injuries and genitourinary, chapter 30. Anybody have any questions? Nobody?
Actually, I do have a off-topic question about something that was on one of the modular or the midterm.
Okay.
I think there was a question about removing a knife in the back. Now, if that impedes with CPR, would you remove it from the, I know it says from the book you can do it out of the chest or a cheek, but like, can you remove something out of the back if it's impeding with CPR?
Yep.
Okay.
Yeah, anything really that interferes with our ability to do CPR can be removed. Just document it carefully. You know, don't leave yourself kind of hanging in the breeze with that one.
Okay, thank you.
Yep.
And then Tommy, we won't get the test scores for the most recent module just because it was set for Tuesday night, correct?
I saw that only one person still actually needed to complete that. So I'll open it up as soon as the last person finishes up. So it won't be Tuesday night. It can be today, tomorrow, whatever. But yeah, one person still has to do it. And once they do, I will open up the module. Oh, good. We're going to talk more about sexual assault. Isn't that fantastic? All right. Chapter 23 is gynecologic emergencies. This is going to be probably a little less trauma, a little more medical, but it buttons up hang on just 1 second. Because looking at what we got versus what else we need to do. All right, somebody refresh my memory. Did I say 30 and 31 today or 30 and 23 today?
30 and 23.
Okay. Then gynecologic emergencies it is. All right. So this is a short lecture. We're going to take another 15-minute break before we start this one off. And whenever we finish this, we will be breaking for lunch and then come in for practical time. So I'm going to put up another 15 minutes, and when we come back, we'll cruise through this and we'll be done.
Cool beans.
Chapter 23, Gynecologic Emergencies. So this really is sort of just cruising through some stuff that we've already covered in anatomy and physiology, some stuff that we just finished covering, and talking about sort of the kickoff pieces to when we get into OBGYN and baby delivery and caring for the neonate and all that stuff. Be forewarned as we get into some of these special patient population type chapters. 15% of all of the questions on your national registry exam can come from pediatrics. I must have been getting them right because I got just about every single question under the sun about OBGYN, baby delivery, and care for the neonate when I took this exam. So I know there's a lot in medical, there's a lot in trauma. You guys are shouldering the load, but don't let these sort of topics kind of slip, because they do ask a lot of OB questions. They do ask a lot of pediatric and baby type questions. And some of the stuff I'll highlight extra just to make sure that we stay sharp on that, because there's some stuff coming up, I think tomorrow, that I probably answered 10, maybe 12 questions on my own registry exam. So let's file this under the common sense department. Women are uniquely designed to conceive and give birth. So not only conceive, not only give birth, but they grow humans inside of them. They are absolutely susceptible to problems that do not occur in men. At no point in my life will I be able to grow a human. Sure, the conception portion of it, I can be there for that. I can be part of the whole job, but they are going to be where this baby lives on the inside for the first 40 weeks. And we need to start looking at some of the anatomy and physiology and talking about some of the more patient-specific things that can come up with them. First, we're getting into the anatomy and physiology a little bit. We have the external female genitalia. So these are all the outside pieces that we just talked about. We have the vaginal opening, the labia majora and labia minora, and the clitoris. From there, now we're going to get into our internal anatomy. The internal anatomy is the ovaries. They lie on each side of the bottom, so the inferior most bit of our abdominal pelvic category. The ovaries are left and right respectively. They produce an ovum. The ovum is the egg that gets released, travels down the fallopian tubes and into the uterus whereas it is either fertilized and starts to become a zygote and a baby, or it is expelled every 28 or so days in a woman's regular menstrual cycle. The uterus, we talked about this in the last lecture, is a hollow muscular organ that grows with the fetus as the fetus grows and develops. So it moves further up into the lower portions of mom's anatomy of her abdominal cavity. The vagina is the outermost cavity of the woman's reproductive system. That is the birth canal that a baby travels through when it is being born. So we'll look at a picture here. We have our ovaries here where the eggs are produced. That egg will travel down the fallopian tube and either wind up fertilized and implanting somewhere in mom's muscular uterus, or will be expelled after 28 days. Ovulation is when that egg has been released and is about to be either fertilized or expelled. Menstruation begins at puberty. The onset of menstruation, they love to ask definition questions. Menarche. Menarche is the onset of menstruation. It's generally sometime between the ages of 11 and 16. Ovulation and menstruation will then continue until menopause. Menopause is when a woman is no longer physically releasing any more of these eggs to be fertilized. There's no real solid number, but it's sometime between the ages of 11 and 16 is when normal menstruation begins, and sometime around the age of 50 is when women start to experience menopause. Every month, one ovum is released into the fallopian tubes. That is when ovulation happens. The process of fertilization begins when sperm are deposited into the vagina, and they pass through the cervix up into the uterus and actually will fertilize that egg in the fallopian tubes. If that egg happens to implant in the fallopian tubes, we'll talk about what that will present us with as far as a problem. Because let's go back a couple of slides and take a look at our fallopian tubes right here, and then compare it to what the uterus looks like. What's something you notice right off the bat? Is a baby going to be able to grow in that tube?
No, it's way, way too small.
Yeah, it's way too small. So we can actually make some clinical decisions and some clinical evaluation of our patient to find out, do they maybe have an ectopic pregnancy, which is what it's called when that baby begins to implant and form inside that fallopian tube. That can be absolutely a life-threatening situation for mom, and it might only present as some abdominal pain. So if fertilization does not occur within 14 days of ovulation, that is generally when the menstrual period will begin. Menstruation will begin. The lining of the uterus will actually begin to slough off and separate from the uterus. And it is really just cleaning itself in preparation for the next 28-day cycle. And that is when a woman's period begins. There'll be some bleeding, there'll be some passage of tissue. Normally it lasts 5 to 7 days or so. And from there, the whole process starts all over again. It is 28 days, pretty much like clockwork for most women. When we talk about gynecologic emergencies, the causes can be widespread. They can range from pretty simple, like an STI or an STD, sexually transmitted infection or disease, or it can be this large-scale catastrophic trauma that causes all sorts of issues for mom, both right now and going forward. I keep saying mom too, because I got in I do this lecture and I get in the OBGYN mode. So how about just our female patient? Doesn't necessarily have to be mom. Pelvic inflammatory disease is the first one that we're going to talk about. It is infection of the upper organs of reproduction. So that means the internals, not the externals, the uterus, the ovaries, and fallopian tubes. Most common in sexually active women, period. It can occur other times, but it is most commonly found in women who are sexually active. Can result in the increased risk of ectopic pregnancy or a patient actually becoming sterile. If we have inflammation of the uterus, the ovaries, and the fallopian tubes, and scar tissue beginning to form, and some pretty significant type problems on the internal products and organs of conception, we're going to have risk of sterility. Generally, this is a patient who's complaining of a general lower abdominal pain. All of these things are pretty much right in the same neighborhood. So our patient's not going to have really hugely specific type complaints. Moving on down the road, now we're going to talk about sexually transmitted disease. Sexually transmitted disease can lead to pelvic inflammatory disease. A sexually transmitted disease that isn't treated is eventually going to creep its way up into the internal parts of the body. When we talk about true for life STIs and sexually transmitted diseases, we will see more external problem, more external sign and symptom. Chlamydia being one that they say is the most common, usually has mild to absent symptoms for most females. Can be spread from the rectum as well, and it can progress into PID. Females, a lot of times with sexually transmitted diseases, will be relatively symptom-free, or it won't be anything that's really altogether hugely abnormal for them. So that infection just kind of goes on unchecked and unchecked and unchecked, and can eventually lead to that pelvic inflammatory disease. Next, we have bacterial vaginosis. It is a vaginal infection, and it doesn't necessarily have to be, from anything specific. There are bacteria in the vagina to begin with, and bacterial vaginosis, yes, it can be a sexually transmitted disease. Yes, it can lead to the pelvic inflammatory disease and some pretty diffuse lower abdominal pain. But this is something that can just be an uncontrolled, unchecked growth of the natural flora that is inside the vagina. If it's untreated, we can talk about things affecting the ability to conceive a child, low birth weight, and PID, sure. It is just going to make the patient more susceptible to more serious infections. And the same goes for gonorrhea. Gonorrhea grows and multiplies rapidly in warm, moist areas. So the reproductive tract is lined with mucous membranes, heated to 98.6 degrees, where all bacteria in the world just love to be. We can have a whole laundry list of symptoms that will go along with gonorrhea, and especially in the female patient. We can have severe infections. There can be cramping and bleeding, abdominal pain, nausea, vomiting. The thing that leads us to believe that this is a problem for the patient is these are all sort of signs that your patient's going through their normal menstrual period, but this is happening between them. So when the problem is actually occurring is going to tell us, is this normal for my patient, or is this something that's abnormal for my patient? It is very infrequent that somebody picks up the phone and calls 911 for these kinds of problems. Generally, once they do, it is a problem that has progressed and been going on for a very long time because they're easily treated. You go to the doctor, they prescribe you some medicine, most of these things go away, and your patient goes on about their day perfectly happy. When it gets more towards the area of becoming that PID or the pelvic inflammatory disease, and the infection is now moving from the outside of the body to the inside of the body, is when we start seeing more complaint, more pain, more discomfort, and maybe more activation of 911. Now that we've gotten through that, really the last little bit that we have to talk about, told you this was a short one, is vaginal bleeding. So vaginal bleeding is something that happens anyway, but this would be vaginal bleeding that is outside of my patient's menstrual cycle, or their menstruation is different for one reason or another, which led them to call 911. So it would be an abnormal menstruation. Trauma to the vagina is what we talked about in the last lecture. We mentioned ectopic pregnancy just a few slides ago here towards the beginning. Spontaneous abortion is the $10 medical word for miscarriage. Cervical polyps can grow inside the cervix or inside the uterus, so we can have just little, almost like skin tags that grow off of a patient's cervix that can cause things like the cervix to remain open and some pretty continuous bleeding. And then last but not least, we can have cancer, and it can also cause some vaginal bleeding. Scene safety and BSI are going to be the words of the day for a lot of this stuff. Always, like I said, have in the back of your mind that part of this could have something to do with a trauma or be of some sort of assaultive nature. If you think there's been an assault, we're mandated reporters. We need to call the police. Thankfully, you guys generally will have the police on scene with you. Just think large amounts of blood. So I want to keep things that are wet and sticky and not belonging to me off of me. As far as mechanism of injury goes, it may be pretty easy to understand how someone has gotten themselves into this situation. And really, it's not altogether that important to us. But we are mandated to report things like sexual assault. Much like the rest of our assessment technique, we are going to form our general impression. We are going to evaluate and treat airway, breathing, and circulation. We are going to assess breathing for rate, rhythm, and quality. We are going to check skin, color, temperature, condition. We're going to check pulse, rate, rhythm, and quality. We're trying to identify what? What do you think we are looking for when we're evaluating our gynecologic patient for things like skin color, temperature, and condition?
Internal bleeding?
Internal bleeding, external bleeding, any kind of bleeding. Because it is a vascular area, it has an almost unlimited ability to cause hemorrhage. When we get into ectopic pregnancy here in just a couple of slides, or tomorrow when we do the actual OBGYN lecture, we'll talk about how much bleeding and how much pain and how much problem that these areas on our female patient can cause, just based on the fact that it is their job to be vascular. It is their job to supply lots and lots of blood flow to a developing baby. Remember, it's one of those, like, yes, they are uniquely designed to grow and support life. Investigate our chief complaint? Sure. What we're going to be talking to this patient about, it says some questions are extremely personal. Patients are not going to be comfortable discussing these things. This is not something that is, Well, on my Monday things to do is to talk about pelvic inflammatory disease and the fact that I think I might have had chlamydia for a really long time. Or I woke up this morning and I was covered in blood and I don't know where it's coming from, but it is all in my lower portions. So do what you can to protect your patient's dignity, protect your patient's privacy. This is always one of those situations where anybody who is not necessary gets the gate. See you later. You don't need to be here. Thanks for coming. Thanks for your help. We'll see you back at the station. If my patient's complaint has to do with abdominal pain, ask some questions. Make sure you get the OPQRST. Make sure you ask, does anything make it better? Does anything make it worse? How about associated symptoms? What do you think some associated symptoms to go along with getting a history of our OB emergency patient would be? Think of some questions you'd want to ask them, some things that you'd want to know.
How long has this been going on? Has this happened before?
All good questions.
When was your last period?
Bingo. Because what we're starting to think about with this patient is there any possibility that this patient could be pregnant? And is there any possibility that something very, very negative is ticking away like a time bomb on the inside? You know, it's important to ask, you know, when was your last period? Is there any possibility you could be pregnant? Maybe not in a room full of people. Maybe not if your patient is, you know, 16 years old in front of mom and dad. You know, there's some tact and some back and forth with your patient, but it's important to make sure we're getting all of our information so that we're not overlooking something. If our patient's got a vaginal bleed that is significant enough to call 911, we still OPQRST. We're also going to ask how many, whatever they use to soak the blood up, how many have you gone through? Why do you think I would go out of my way to ask that?
See how much blood loss?
Yeah, how much blood have you already disposed of before you decided that this became ridiculous and you needed to call an ambulance? You know, some associated symptoms to go along with that would be syncope or lightheadedness. If your patient goes to stand up and gets woozy, it's telling me right then and there that they've soaked through a lot of pads, towels, whatever, and now it's also very likely that they're about a quart low and probably in shock. Even if I don't see anything else that points me towards shock, maybe they're not pale, cool, diaphoretic, maybe they're not tachycardic. Just that quick stand up and change the amount of pressure that's in their system, causing them to be lightheaded and almost fade out, is telling me that this patient likely has experienced some sort of hemorrhage for probably an extended period of time because they didn't want to call 911 and have 2 firefighters show up and start asking them these questions. And they've probably used a great big number of these. And until proven otherwise, you'll never convince me that this does not exist. And there's no actual test to prove whether they are hypoperfused or not. So you will never, ever move me from that spot. If there's an uncontrolled hemorrhage and my patient shows signs and symptoms of syncope, I don't need to see all the really negative shock stuff. Our sample history, make sure we ask about birth control, either pills, shots, IUDs, you name it. Make sure that we ask about their last period. Make sure that we ask if they have any other medical problems associated with what they're telling us and what's going on with them right now, because it's going to help in the long run. And maybe they don't have to answer those questions 25 times if we get it and pass that information along. Some pertinent things to keep our finger on here as far as assessment goes. Blood pressure, heart rate, skin color, temperature, and condition. I know Kevin mentioned to some of you briefly about orthostatic vital signs. So this is that change in heart rate and blood pressure when your patient goes from laying down to seated to standing up. Your patient who has a syncopal or who has a near syncopal probably has orthostatic changes to their vital signs. When they go to stand up, they get dizzy. Why do you think they get dizzy?
Not getting that blood back to the brain.
Yeah, so what's their blood pressure going to do?
Drop.
Their blood pressure is going to drop and their heart rate's going to go up. Those are orthostatic changes to your patient's to your patient's vital signs. We may see some distension and tenderness in the abdomen. We may see visible bleeding from the genitourinary areas. We may see some neurologic mental status changes. You may not always get to see that huge amount of blood that we talk about, but if you're starting to see problems here and here and here, in a patient who has a near syncopal, or you're having a difficult time keeping awake to keep talking to you, on the list of things that the problem could be, is there a lot of things? You know, you would think if this was a drug or alcohol overdose, that we wouldn't have those orthostatic changes to the blood pressure, to the pulse. Those would just be, all right, central nervous system depressant. That central nervous system's depressed, so blood pressure is going to go down, heart rate's going to go down, skin color will be crappy, but we expect those things. If we have some form of underlying unknown hemorrhage or septic type infection, we're not going to see those necessarily like stereotypical, all right, this is this, this is this, this is this. We're going to start to see those signs and symptoms of shock developing, even if we can't put our finger on what is actually causing it. All right, well, they aren't allergic to shellfish. They aren't allergic to this. They aren't allergic to that. They have some distension and tenderness in the abdomen. Bleeding has been described as a lot heavier than their normal menstrual period. And when they stood up off the toilet this last time, they had a near syncopal. Does that really sound like terribly crazy, like holy buckets, this patient's gonna die?
No, not at all.
No, it doesn't sound big and scary and crazy, but the deeper you dig, it does, when you use a little bit of your assessment, start to sound an awful lot like that, doesn't it?
Yes.
And you can't prove one way or the other, but you are seeing some of the more subtle things that kind of wave back at you and go, hi, I could be a patient on my way to shock and being dead before lunch. Our physical exam should be very, very limited. Only if absolutely necessary would we ever do an actual physical exam of the genitalia. If my patient's telling me that it's bleeding or there's something weird going on, for the most part, unless they are absolutely just covered in blood, that's good enough for me. I don't need to go making their bad day worse. My job is to make their bad day better. So our emergency medical care for these patients is pretty straightforward. We want to maintain patient privacy and dignity. We have sanitary pads in the truck for this reason. We are going to control the bleeding with that as best we can. We're going to document the number of pads the patient has used. We're going to document the number of sanitary pads that we have used. If it's injury to the external genitals, we already covered this pretty straight. Going to be very, very painful. We're going to treat this just as we would any other soft tissue injury. And this is like the third time that they've mentioned this in just today's lectures. So please, please, please do not pack or place dressings in the vagina. Some of these bleeding problems may actually be sort of the way things are supposed to work. We don't always want to stop non-traumatic bleeding because that might be what is actually keeping the patient okay. It could be a pressure problem, and that blood is going to find the easiest way to get out, and stopping that bleeding might not be beneficial to our patient. If it's pelvic inflammatory disease, generally the primary complaint is abdominal pain. Our treatment is very, very limited. Care and comfort, monitor our ABCs, monitor our vital signs, and just go out of your way to be nice and try and keep the patient as comfortable as possible. Let's see, sexual assault we already covered, and that's a wrap. That's our introduction to our OB patient.